Well, good morning, everybody. On behalf of the Bipartisan Policy Center, I'd like to welcome you to today's event focused on increasing access to treatment for obesity. My name is Dr. Anand Parikh, and I serve as BPC's Chief Medical Advisor. I just want to say at the outset how nice it is to be here in person and actually talking to people as opposed to talking to a computer screen. I think this is one of our first hybrid events for the health program since the onset of the pandemic. So great to see everybody in the room. And special thanks to the over 500 people online who have virtually agreed to participate today. Welcome, and we look forward to your participation as well. Today's event is co-sponsored by BPC and the University of Southern California's Leonard D. Schaeffer Center for Health Policy and Economics. In addition, BPC has received support from Eli Lilly. I'd also like to recognize Shanna Kristrup, BPC's Public Health Director, and BPC Health Program staff Emma Sheffert and Jen Ruff for organizing today's event. Woo. We have an excellent lineup for you of speakers today. We'll hear from Dr. Dana Goldman first. Dana is the Dean of the USC School of Public Policy and co-director of the USC Schaeffer Center for Health Policy and Economics. We'll also hear from Christy Gallagher, Research Project Director for the Stop Obesity Alliance and Senior Center Administrator for the Redstone Global Center for Prevention and Wellness at the G.W. Milken Institute School of Public Health. And we'll hear from Dr. Kimberly Guzzoni, Associate Professor of Medicine and Health Policy and Management at Johns Hopkins University, where she also directs the Healthful Eating Activity and Weight Program. We're also pleased to host Rachel Kors, Washington correspondent at STAT, as our moderator for the discussion today. We look forward to your participation as well, so please join the conversation at hashtag BPC Live or at BPC_bipartisan on Twitter, or enter your questions into the chat. I want to start off today's event with a bit of framing and a summary of BPC's activities in this space. Over the last several years, BPC has tackled both the broader economic and environmental determinants of obesity, in addition to enhancing the role of the healthcare system in treating this medical condition. With respect to the former, BPC's recent Food and Nutrition Security Task Force completed 3 reports related to COVID-19, related to COVID-19 and food insecurity, related to child nutrition programs, as well as a supplemental nutrition assistance program. With respect to the latter, BPC is focused on healthcare professional competencies on the prevention and management of obesity care and the adequate reimbursement for effective evidence-based behavioral therapy and community-based interventions that address overweight and obesity. More recently, BPC released a report focused on access to obesity treatments for older adults. And I want to just take a moment to go through the key study findings of this report. As background, the prevalence of obesity amongst older adults aged 60 and over is 42.8%, similar to the level among younger and middle-aged adults. And the prevalence of class 3 or severe obesity in this population is 5.8%. Low-income Americans and racial and ethnic minority populations are disproportionately impacted by these numbers. Obesity adversely affects every system in the human body because individuals tend to gain weight as they age, and duration of excess weight is also a risk factor for adverse health effects. Older adults are far more likely to be diagnosed and treated for obesity-related conditions. In addition, 70-year-olds with obesity can expect to face 2.8 additional years of limitations in activities of daily living, 2 years of which will involve moderate to severe levels of disability. Obesity also generates enormous economic consequences. Older adults with class 1 obesity incur roughly $2,000 greater per capita annual medical expenditures than those with healthy weight, and adults with class 2 or 3 obesity incur over $4,000 greater per capita annual costs. Overall estimates suggest that the lifetime costs of obesity for a 65-year-old adult are $22,670. Multiplying this figure times the current prevalence of obesity amongst Medicare beneficiaries yields a staggering $524 billion in lifetime Medicare expenditures attributable to current beneficiaries with obesity. Currently, Medicare coverage for obesity treatments is limited to bariatric surgery for beneficiaries with a BMI greater than or equal to 35 with comorbidities, intensive behavioral therapy for beneficiaries with a BMI greater or equal to 30, and if you include overweight, since 2018, the Medicare Diabetes Prevention Program for beneficiaries with a BMI of greater than equal to 25 with a diagnosis of prediabetes. So to assess the effectiveness of obesity treatments that CMS could consider covering under Medicare, BPC conducted a systematic review of randomized controlled clinical trials that evaluated non-surgical, commercially available weight loss interventions of at least 1 year in duration that are currently not covered by Medicare. The literature review revealed that the included anti-obesity medications, which include the new GLP-1 agonists, led to 6 to 16% weight loss in 52 to 68 weeks. Then in-person behavioral interventions led to 5 to 7% weight loss, statistically significant at 12 months, suggesting that these treatments have the potential to improve health. 16 of the 21 studies included in our review enrolled participants over the age of 65. No studies looked exclusively at the 65 and older population. Given the study findings and the fact that obesity is now recognized as a chronic disease and that there are now FDA-approved medications for obesity, the BPC study recommended that policymakers should remove the statutory prohibition on Medicare Part D coverage for FDA-approved anti-obesity medications. Further studies in the older adult population could help CMS in their consideration of coverage for treatments. In addition, BPC recommended that policymakers should expand access to existing evidence-based obesity treatments, such as intensive behavioral therapy and the Medicare Diabetes Prevention Program, including specifically by expanding the types of providers eligible to bill Medicare for the delivery of intensive behavioral therapy and the settings in which reimbursable intensive behavioral therapy may be provided. In closing, I'm sure my colleagues will be getting to all of these points in far greater detail during today's event. And so with that, let's go ahead and proceed, and we'll start with Dr. Dana Goldman. Dana?
Thank you. And like any good academic, I'm going to present some slides. So I hope you'll bear with me. But I think you've done an excellent job summarizing the literature and the fact that innovation has actually allowed us to think about how we deal with a problem like obesity differently than we have in the past. And so here are the disclosures. But I'm going to come over here and speak from here so I can see what I'm talking about. But I do think it's interesting to look back at the last century because this is not a unique problem. If you go back to the 1950s, when we were talking about high blood pressure, there was, when we were talking about high blood pressure, really the only way to address it effectively was exercise and diet, which really meant reduced salt consumption. And what happened is in the 1950s, we started to develop diuretics, and these were followed by beta blockers and calcium channel blockers and the like. But if you actually look back at that history, 20 years later, people were talking, there was significant resistance to clinical acceptance of antihypertensive therapy. Now, think about all the people who suffered in those 20 years because we didn't persistently adopt antihypertensive therapy. And I got my start working in HIV, and when we developed highly active antiretroviral therapy in the mid-90s, we reserved access to that for people who had who were very immunocompromised. And we did some work with HHS where we demonstrated that if we had been more aggressive in treating that, we actually could have eliminated, perhaps because it's an infectious disease, eliminated HIV in the United States. So what changed in the context of hypertension? Well, Mary Lasker, whose name is famous around here, and President Nixon actually intervened to organize the National High Blood Pressure Education Program. They mobilized federal agencies, major national organizations, the states, and the like to say we can treat hypertension. We don't just have to rely on lifestyle. And so the question is, do we need similar policy mobilization here? Now, this is a very complicated slide. I will explain it, but it's years ago. But so the way we measure obesity often is measured by height over weight squared, BMI, and you mentioned the classes. But if you think about what this slide shows, so this is for white males and white females. But if you think about someone with a BMI of 40, which I think is class 3, so right on that cusp, what the height of the bar shows for each age group, the years of life lost associated with that level of obesity. So for someone at a level of 40, you're talking about maybe who's in their 20s, you're talking about 5 or 6 years lost if they're a male, and if they're a female, I know it's hard to read, it's more rectangularized by age, but it's somewhere between 4 and 5 years of age. And you know, what is an I'm an economist, and what does that mean? I'm good at multiplication. So I take all the people who are in this weight class and I multiply them by 4 years of life, for example, and then I say, how much is a life year worth? And each life year, you know, we can argue what the valuation is, but it's probably around $150,000 a year. And what you quickly realize is you get numbers that are much higher than anyone would expect. And Anand was talking about the economic costs, that is the medical costs associated with this illness. But what I'm going to argue is that the morbidity and mortality effects are also should drive policy here. And similarly, you know, another way to look at this is to say, ignore the effect on life expectancy. What about health-related quality of life? Because you brought those up. You know, and this is some research, again, from 20 years ago where we knew this, that actually showed that being in a BMI of 30 plus, which is defined as, some would argue, as a definition of obesity, results in a lower decrement, so this is the size of the decrement in quality of life, than smoking or aging 20 years. And so that, I think, it provides another metaphor for thinking about the morbidity aspects. So, and as you pointed out already, you know, if you look historically, the average American adult is quickly going to be considered in this class of obesity, okay? And so, and add on to that, you already mentioned the prevalence in Medicare, but I think when you look at it by race or by ethnic group, what you really see is some substantial disparities. So here's the level of obesity for Blacks, Hispanics, and whites, and all these numbers are startling, but it's particularly startling for Blacks and Hispanics. And you know, as you classify this, even in that group, remember that BMI 40 plus group I told you is a group that could lose 4 years of life. You're talking about 14% of Blacks in Medicare who are having this decrement or associated with this loss of life. And it's a rather chilling statistic. And you know, you can see this when you start looking at the sequelae of obesity, as you already articulated: diabetes, hypertension, heart disease, and disability. So health suffers. So, you know, like I said, a lot of these studies, I purposely took studies that are 20 years old because we know this is out there. And we've been sounding the alarm for a long time, and yet nothing has changed, or things have changed, but rather slowly. And obesity is still often viewed as a lifestyle choice rather than a serious health concern, creating stigma around treatment. And if you look at the uptake of the available treatments that were summarized, so it's rather remarkable. It's 3% or less. And you know, when we passed Medicare Part D well, almost 20 years ago now, and added the drug benefit, people were very worried about getting access to treatment that was a lifestyle treatment and that the government would be paying for something that was of questionable value. And so they were specifically excluded from weight loss. And the issue is, and private insurers often match what Medicare does, and the result has been that people have treated these at arm's length and with skepticism as a potential and viable treatment option. And so along comes, and I think we'll talk more about TROA, the idea behind the Treat and Reduce Obesity Act is to allow Medicare coverage for FDA drugs and to expand access for intensive behavior therapy. But if we're going to deal with this problem, we're going to need multiple modalities because the prevalence is so high. And it also means that a recognition that people who are young become people who are old. When I remember getting my start, the first time I came to Washington, I was working at the Rand Corporation, and I came to Washington and I gave a presentation to, at that time it was HCFA, not CMS. And I said, and the presentation was Medicare could actually save money if it treated hypertension for people in their 50s. And everyone in the room said, yeah, but we don't cover drugs. And so why would we ever do that? And so really the public policy, and there's a bit of that going on today as we talk about obesity. And so what we did, and I'm not going to go through the details of the modeling, is we used, at the Schaeffer Center, we have a team that has built something called the Future Adult Model. And this has been funded by NIH for 25 years. CMS, the MacArthur Foundation, the Department of Labor, and others. And it's designed to think about the population health consequences of new innovation. And what we looked at is a couple variants where Medicare covered the anti-obesity treatment and there was universal uptake. So this is thought of as what are the benefits if we address the entire problem. And we also did a scenario, Medicare plus private coverage, which recognized that often private insurers will follow what the government is doing. And what we would see from this, not surprisingly, is a really dramatic reduction, obviously in obesity, because these drugs are so effective. But also, you're talking about a world where perhaps after 20 years, and this takes time to percolate through society, but diabetes prevalence would fall by almost 8 percentage points. In other words, 1.8 million fewer cases of diabetes over the next 10 years. And if private insurers follow that, you more than double the effect. You're talking about 4 million fewer cases of diabetes and a reduction in prevalence of 17 percentage points. And again, as I said, economists are good at kind of multiplying, doing math. And so what you see here are kind of the Medicare cost offsets. So what I haven't told you about is the cost of the drugs. And I think we'll spend a lot of time talking about that because what you're talking about here is potentially some huge costs. But it's also important to understand there's a lot of offsets to the program. Part A, Part B, and Part D on the order of, in 10 years, you'd see $175 to $250 billion in savings. And, this is the kind of thing that CBO is notoriously bad at, I might add, which is why we have to do it at the Schaeffer Center. But the other thing I want to point out is the health benefits, because I still want to recognize that. The criteria for an act like this should not be, does it save the government money? For years, I served on the CBO's panel of health advisors, but I got a little tired of coming to Washington from California, and there would be all this hand wringing because the population was aging. And I said, isn't that the point of all the spending, to keep people alive? So the health benefits here actually swamp the Medicare cost offsets. We're talking about $1 trillion in savings. And when you start valuing the reduced disability and the like, and we have a white paper that's out today, it goes through all these details. But we're really talking about potentially $1 trillion in benefits. And the question, though, is how do we, I don't know how I'm doing on time or not. So this is my last slide.
Good. Perfect.
Yeah, that's what you wanted me to do. So here we have, there's savings to Medicare, potentially trillions in health benefits, could alleviate some serious health disparities in older populations. And the drug expenditures here would be substantial, and Medicare drug pricing would come into play. And everyone kind of knows that, but I do want to point out something else. Like, if you're talking about treating 50% of the population, there are already limited supplies of this drug. For those of you, I'm a type 1 diabetic and I'm on Ozempic, so I know this firsthand. And oftentimes my pharmacy will say, I can't get you the drug. How are we going to scale up this manufacturing? Are we going to get private companies to do this? Would they be willing to scale up this type of manufacturing, knowing that someone might come and try to claw back some of the profits? And so we really need to think about novel pricing solutions. Are there some lessons from things like COVID, where we had guaranteed payments and the like, that could really help address this problem? So with that, I will stop. Thank you.
Thank you. And thank you, Dana, and thank you to the BBC and all the panelists here this morning to come together to talk about this really important topic of obesity. It is true that we really do need access to obesity treatments to be available for everyone who wants and needs it. But the reality is, as you pointed out, that the utilization of these benefits, when they are available, is more likely to be closer to 1% to 2%, and not just for drugs. Why is this? Well, one reason is that patients are reluctant to seek care. Data from a recent Observe study that looked at barriers found that only half of the people living with obesity actually identify themselves as having obesity. And those who do don't believe it's a disease. They believe it's a condition that they are responsible for and that it's something that they personally need to do something about. I was, and to some degree, still am, one of those people. I've struggled with my weight for most of my life, but I never wanted to identify myself as a person living with obesity. I have a genetic predisposition to obesity and to type 2 diabetes. And like many women, I gained an excess of weight after my 2 pregnancies. And then about 7 years ago, while one of my children was facing a life-threatening illness, I gained a lot of weight because I am a stress eater and I also did not exercise. So after having a hysterectomy and having one of the providers who worked on me, and I went to see him after for the follow-up, and he told me, you really could lose some weight, but he didn't give me any tools in the toolbox. I began to feel like it was time and I was ready to focus on my health. I went to the Obesity Action Coalition's website to learn about all the available treatments that are out there. And after trying a commercial weight loss program for 6 months, where I lost 5% of my weight but then plateaued, I went to my primary care doctor. I was lucky because my primary care physician was open to discussing treatment options with me, but very few people actually have access to clinicians who have been trained in obesity medicine. Research that we conducted at the Stop Obesity Alliance in 2018 found that most providers lack knowledge and understanding of recommended obesity treatments such as behavioral counseling and pharmacotherapy. And many are just reluctant to prescribe medications that they are unfamiliar with. So they fall back on the tried and true, eat less and exercise more. How many of you all heard that before? So when my doctor and I discussed my options, she prescribed one of the newer anti-obesity medications. And again, I was lucky because I have health insurance that covers medications. But as Dana pointed out, obesity care is often not covered by health plans, or if it is, reimbursement is poor. Again, our research at STOP has looked at coverage for obesity treatments in state Medicaid and state employee health plans over the last decade. And while we have found pretty consistently that states cover prevention, screening, and even bariatric surgery, less than half of the states covered medications in either state Medicaid or state employee health plans. So how do we solve the fact that our fragmented healthcare system makes it difficult to know what care is available and how much it costs. One solution we have come up with at STOP is to offer a comprehensive obesity benefit. That benefit is evidence-based, and it should provide prevention and screening for obesity, referral to intensive behavioral therapy for those with stage 1 obesity and above. That should include counseling, nutritional therapy, and physical activity. Access to all FDA-approved anti-obesity medications, access to metabolic surgery, and maintenance strategies to help those who have lost their weight stay and mitigate their weight in the future. But it has been literally impossible to find health plans that actually offer such a benefit and make it easy to find. The good news is, most recently, the Office of Personnel Management, which provides the guidance for the federal employee health plans, issued new guidance on obesity treatment that mirrors our recommendations. It specifies that all plans must cover screening and prevention, intensive behavioral therapy, anti-obesity medications, and metabolic surgery. But until more health plans actually offer these benefits, until more providers are trained and actually provide obesity care, and until patients demand such care from their providers, we are going to continue to see utilization that is lower than 1% to 2%, and patients feeling like it is their fault that they can't lose the weight and keep it off. Thank you.
Thank you. So this is really a perfect segue in thinking about the provider challenges. And really, I think that those of us who work in the obesity medicine space really share the same concerns as our patients do. Just highlighting some of these things that we're sort of facing every day. I think the first one really is the lack of training. When I think back when I was in medical school and residency, the amount of time actually spent on obesity was a handful of lectures. And it really doesn't communicate or equip our physician and other clinician workforce to actually treat a very complex chronic disease. And so we're a little bit at a disadvantage. I think one of the really exciting things is that the younger generation of physicians, so the trainees that I work with every day, they understand that obesity is a chronic disease. We're not really having to make that argument with them anymore, but they're still not necessarily getting the education that they need to actually treat the condition. That's been a slow process, and I think empowering physicians and other clinicians to really understand the disease, how to treat it, is critically important. I myself had to go and get additional training. I went and I got certification by the American Board of Obesity Medicine to really show that this is something that I know how to do and that this is a safe place for patients to receive care. So how do we support clinicians who are very busy with multiple competing priorities? Identify this not only as, yeah, I need to do this, but how can I actually go and take the time to do this? I think the second point that I'd like to make is regarding the current design of the intensive behavioral therapy benefit. When that was initially passed, and there was a lot of excitement, and then we read what it exactly was, and then, well, this is a great first step. However, the designation to have this done within a primary care setting, sort of you're falling into the fact that then you have a physician workforce or clinician workforce that isn't trained to handle this, but they are sharing the entire burden to try to deliver this benefit. The other thing is that it didn't really take into account of how primary care actually operates. So if most of you think when you go and you see your primary care provider, you're lucky to get 15 minutes with that person every 6 months, and that's like a good situation. The structure of the frequency of the visits is not set up to be what the reality of practicing primary care actually is. I think the other final thing of putting this as sort of a preventive service and reimbursing it as such is a further disincentive in thinking about primary care providers trying to make ends meet with their practices. Primary care is really not in the business of making tons of money. We're about serving our patients. But if we're losing money in trying to deliver a service, that's how do we pay our staff? How do we support our families? We need to think about sort of adequate compensation for that. and extending who can really offer these services, given that that educational gap is not going to be solved overnight. There are providers out there that do have more education and training that are willing and ready to take up this charge and work in partnership with physicians and other prescribers. And so we really need to think about a different dynamic there. My solution to sort of solve that to date has been, creating my own multidisciplinary clinic that sort of extends outside that benefit, but it would be lovely to actually take up and be able to use the provision of services as they are outlined. I think the final thing in just talking about AOMs, which are a key part of my practice, and a lot of referrals I get is really physicians and other prescribers are nervous to prescribe these medications, again, sort of stemming from that lack of training, and so they know that they can come to my clinic, have a full evidence-based shared decision-making discussion about what are the right options for that individual person. So I think it's been very exciting with I'm fortunate enough to practice in sort of the larger DC area and then work with a lot of patients who are federal employees, and with the expansion of that benefits coverage since January, it has actually been life-changing, not only for my patients, but also for me in the way that I'm able to practice. To be able to actually engage in a true shared decision-making conversation about the risks and benefits of not here's the one choice that your insurance will cover, or this is the one medication you can actually afford to pay for out of pocket. To be able to go through all the options is really empowering for patients, that they feel like they have choice, that they are recognized, that this is not all their fault. And it's life-changing after they are taking medications to not have sort of some of that food noise, constant struggles with hunger that were setting people up for failure so often, when we know there is a complex physiology behind this disease and we need to actually treat this with comprehensive tools. So I think I will stop there with that. And again, thank you all, and happy to participate in the panel.
Yes, thanks everybody for this excellent foundation. We did just want to let everyone know that we are taking audience questions. So for those in the room, there are index cards. And for everyone online, you can enter questions into the chat on YouTube or on Twitter using the hashtag BPCLive. So we'll be taking those kind of interspersed throughout the rest of the panel. So please don't wait till the end, get those in, and we'll be sure to incorporate them. So the first question for our panel is kind of about the legislation that's out there. I think Dana kind of alluded to TROA. And I mean, the legislation has been out there for years and has bipartisan support. It's gained more bipartisan support over the years. My question for you all is kind of if you have any ideas as to why that hasn't really gained much traction yet, and whether these new promising medications out there, you feel like that could really make a difference.
So one of the other roles that I play in my day job is the co-chair of the Obesity Care Advocacy Network. OCAN is one of the coalitions that has been trying to produce or help get TROA through. I think there's a couple of different things. One is just the true bias and stigma against this disease. A lot of members, yes, although it's a bipartisan support, and we've had lots of co-sponsors in the past Congresses, there's really been no one who's taken it on as a full champion to get it past the finish line. And one of the ways that we felt that most strongly was during COVID, when we knew that this was a disease that made COVID-19, death was higher from people who were living with obesity and had complications from it. And yet we had an actual possible solution, and we still couldn't get it passed. So it's been frustrating. I would say also the fact that has been a long time for us to be able to get a score from the CBO. And rumors have it that if we were to get a score, it would be quite high. So right now, there is actually not a TROA bill that has been introduced this Congress yet. We're hoping it'll be soon. But the thinking is that they really need to look again at the costs, and maybe hopefully CBO might be able to change some of their projections on that. Again, like I said, and Dana said, what we're seeing as far as uptake on these medications, and even the IBT has been really low. The utilization is quite low. So to project that over 100% of people living with obesity in Medicare would actually take advantage of these medications is really a little bit far out there.
Hey, can I just add something on the CBO score? Because first of all, I don't think they'll do it right. But secondly, I do think that the one problem here is that, they're always stuck with a 10-year window. And I didn't talk about the 20-year window. Again, if you view this as young people today, again, look at those years of life lost for a 20-year-old who is obese. The real gains accrue after decades of solving this problem. This is true. This was true for smoking as well. And that doesn't get scored in a 10-year bill, and it is a really unfortunate thing. And, it's surprising to me that, for example, we have all this spending where we, for example, we subsidize electric cars because we know air pollution is bad, and it's particularly pernicious for the communities that don't drive as much, ironically, and underrepresented minorities. And so we're willing to pay subsidies to improve air pollution and actually spend money. But I don't see an environment where anyone is going in this constitution of the legislature where they're going to spend extra money to deal with this problem.
Mm-hmm. Exactly. And beyond Medicare coverage, we talked about this, private insurers do have the choice to cover these medications and other treatment options if they want to, but there's been pretty lacking options in that department so far. So I guess my question is in part based on a question from our audience about, what do insurers need to see that this is a winning financial proposition for them? Is it more studies on kind of the long-term health benefits? Are there problems with, the long-term health benefits being to Medicare instead of to private insurers? I mean, what's out there? What are the roadblocks for, the private insurance market just acting by themselves?
I guess I'll start. So I think it's important within the private insurer marketplace to realize that it's not just the insurance company. Oftentimes it's folks' employers. So when you talk to insurance companies, they'll oftentimes say, we offer an obesity treatment package, but it's an add-on that employers have to elect into. It's not a default. And so then it becomes shifted onto the employer. Why didn't you sort of make that decision? Which I think there's an equal conversation there based on sort of the cost of some of these add-on obesity policies versus, can we price those in a way that is affordable, or really asking the question, if obesity is a chronic disease, why is it we don't put cancer or hypertension as a special policy? Why should it be its own structure? So I think the question is, can that be embedded within? Or if it continues to remain in the situation that we are, how do we really educate employers, people like benefits managers, and thinking about, in my conversations, is oftentimes wanting a return on investment in 1 to 2 years, which I think data, as you have elegantly showed, is not really the expectation. And as a result, then the buck keeps getting passed with people changing insurance companies and employers so frequently. But ultimately, this all just cycles back around, and ultimately you're going to get stuck with the bill for somebody. It might just not be the same somebody you originally started with.
Yeah, and I think, average tenure in a private insurance plan is about 4 years. That's not going to pay off. I think the really interesting question is, what will Kaiser do? Their average tenure is closer to 10 years. But also, I think we can draw some lessons from what gets done in the UK, actually, because they have an obesity crisis as well. And there, they are bearing the costs of that, literally and figuratively, and they're under enormous pressure. And it will, their health system as a result. And it'll be interesting to see if they can negotiate favorable rates and will provide much broader access. So, there are ways to solve this. And I will say that, we saw private insurers stepping up and covering Hep C drugs, even though Medicare was the primary beneficiary of curing Hep C. But they negotiated very hard to get lower rates. And I think, we'd like to see something like that happen here, where there's a lot of access to different therapeutic competitors that'll drive prices down to a place where, and the evidence base is so compelling that private insurers will cover it.
I think we also need to see more leaders like OPM who came out and said, you must cover all of these, different treatments, including anti-obesity medications. And when you talk to them and ask them why did they do that, one of the reasons they say is it's life-saving medication, right? We wouldn't not cover a drug for cancer or heart disease or something else because, it's life-saving. And so they've made the decision, and, we'll see what it looks like in another year or two, what the utilization is and what the benefits are. But we need more leaders in the field like that.
Absolutely.
And I would like to say one more thing. The one thing that I think TROA didn't address is, are there, again, novel pricing mechanisms in the Medicare program that would allow you to do this? We know there's great difference in the value of this drug depending on your age, your race, your initial BMI, and the like. Are there different ways to price this? For someone who's predisposed to diabetes, there's more value than someone who is not, like you were talking about. And so could we explore this more than just here's the price and we got to buy a lot of it?
Yeah, just to build on that, I mean, you could imagine some novel outcomes-based arrangements that Centers for Medicare and Medicaid Innovation, CMMI, could test. But short of that, there are not a lot of public policy solutions here. The Inflation Reduction Act of recent dealt with inflationary caps, and it dealt with negotiation, but that's many years after the launch of a drug. When it gets to sort of the launch price, there's not a lot that public policymakers can do. It's really sort of manufacturers and purchasers and payers, trying to come up with a solution. And so I think that there's an opportunity here for creativity there.
Mm-hmm. Right, and the patients get stuck in the middle as
That's right.
everyone's
Patients
figuring
and,
it out.
and the physicians and the
Right.
professionals. Right.
That's the other thing I was going to add on, in addition to sort of how things are priced. I think thinking about what is the design of the actual benefit, where, putting in place, multiple complicated prior authorizations and appeals. My clinic, we have a whole team in order to handle that, which is not feasible for most practices to do, which adds extra cost that is, again, sort of a strain on the system. And so thinking about, what are the right gatekeepers, if there needs to be, in putting that on, because really these things oftentimes just result in patients never getting the prescriptions, or they start, but then there's gaps in care or delays, or, I just can't travel around to 10 different pharmacies, as has been some of the recent experiences. That's not something we can really ask everybody to do.
Excellent. So I think, as Christy mentioned, the lawmakers are still kind of in the process of drafting some new bill text to kind of address the Medicare coverage issue, which obviously has downstream implications. I wanted to ask each of you if you had any advice for lawmakers. If you got to be in the room, putting pen to paper, what would you recommend that they, keep in mind?
I'll be very brief. Have a longer horizon when you make decisions, rather than 4 years, which is your legislative term, and 10 years, which is CBO. Start thinking about the future of the country.
I'd be careful with assumptions. Let's not assume that 100% of individuals with obesity on Medicare are going to take this drug. And I think, Kim should talk about it, but I think for many, there are going to be other modalities that you're going to start with. And so looking at the assumptions of how many people, and I think is going to be really important, because that could obviously impact the score in big ways.
I would say try not to play doctor. I think that there are reasons why FDA has approved these medications at certain BMI levels and cut points. And I think if they were to change legislation that that limits that in some way, you're limiting the number of people who are actually should qualify for the medication and not be able to get it.
I think the final consideration I would have them weigh in is that this is not necessarily just about sort of cost savings or what somebody's BMI is. Obesity is a much more complicated disease that has other risk factors, psychological complications, physical limitations, and just impacts on well-being. And so taking that just a pure financial out of it and thinking about the broader context and what this would mean for our population, I think is really important. So it's not just a dollar figure, but the person that's potentially impacted.
Excellent. So we have a few audience questions around the issue of training for physicians, which I think Kim brought up, that if physicians aren't learning about obesity in medical school, then that causes downstream effects, and that there may be some physicians getting training now, but people who've been practicing longer, may not share that perspective. So I wanted to ask all of you just where that comes from. Obviously, the manufacturers themselves have some incentives to do some education to encourage uptake. But where does that start? I mean, is it every medical school in the country's responsibility? Is there any way to kind of encourage that from a public policy perspective?
So there's an organization, the AAMC, that helps determine kind of the curricular content for medical schools. And so there has been discussions and talks of having a specific, this is what a requirement regarding obesity in medical school could be. I think that would be a really important first step of addressing the emerging physician field. But then also thinking about physicians aren't just done after medical school. There's residency, fellowship, et cetera, which is really governed by a separate body called ACGME. And so in thinking of fellowship requirements and residency requirements, actually having something specific around obesity as a competency. That doesn't address the larger kind of practicing pool of physicians out there. And so I think that this is where an opportunity for potentially health systems in thinking about, we have to do continuing medical education for the entirety of our careers. Thinking about putting incentives in place for physicians to go and at minimum get basic competency in some type of obesity training, which there's a number of courses and options out there. And then thinking about for people who do want to have more intense focus in this area, there are options like board certification in obesity medicine, depending on how much of your practice this really wants to be. So I think there are mechanisms out there for that. It's just right now the incentive structure is not in place to really kind of get that ball rolling. Things are built. We just need to activate them.
Absolutely. And Anna, I wanted to give you an opportunity to talk about we have discussed medications a lot. That it's an innovative space. There's lots going on there, but there are also non-medication treatments that aren't covered sometimes, or that may not have gotten uptake. We have seen some support from the White House for non-pharmacologic therapies as well. So I wanted to give you an opportunity to just talk about how medication fits into this larger landscape and how to make sure kind of a full toolbox is kind of included in this conversation.
Yeah, no, a great question. And I think the phrase, borrowing from Dana, the theme for today's event, I think, is multiple modalities. I think that's what we need within healthcare. Intensive behavioral therapy, Christy mentioned the uptake rate is very low. Policy changes could fix that. So you need multiple modalities. I will say we're focusing on sort of the healthcare system today, but you also need multiple modalities of policies outside of the healthcare system as well, right? So what is driving obesity over the last 3 decades is really our food environment, right? And it's food policy, an area that BPC has been really focused on, but food, subsidies and affordabilities and norms and portions and poor diet is the leading risk factor for mortality in the United States. So, we need to continue focusing on those environmental and economic drivers of obesity as well. So we need to be upstream, multiple modalities, but we also need to be downstream. The healthcare system can do a lot. Medications can do a lot. And so I think we need to look at all of these different policies to tackle the challenge.
Yeah, and can I just add to that that, we have tilted the playing field away from rewarding prevention. So I used to say, I have a solution, coin-operated elevators. That'll help solve it. It turns out that's not ADA compliant. But the other part of it is I can't capture any IP on that idea. So let's take a more sophisticated example, an app that actually got us all to go for a walk. That exercise has all these same salubrious effects as some of these treatments. But, we don't protect the IP and we're not willing to spend money to do it. And so it's underprovided in the marketplace. And so we really have to think about how we incentivize paying for prevention of illness rather than just paying for treatment. And that gets back to medical school where, the medical school is designed to treat disease, and that's what they taught. I was on a National Academy panel about integrating the social and behavioral sciences into the medical school curriculum, and everyone else on the panel said no. So, we don't deal with those problems. We have to teach people genetics, and, so it requires fundamental reform.
Absolutely. There's definitely some innovative conversations going on at the state level about like food as medicine and coverage for that sort of thing. But I think that's all the time we have today. Thank you all so much to all our panelists for sharing your wisdom with all of us today. And thanks to all of you for attending.
And thank you to you for hosting and the